couple minutes after here, we've got critical mass here in the Zoom in attendance. And I think with that, we'll get started. So first off, I just want to thank everyone for joining for our next installment here of Cases with Castle Biosciences. My name is Matt Goldberg. I'm a Senior Vice President in Medical here at Castle Biosciences, and I'm a dermatologist and dermatopathologist by training. And it's a real honor to be joined here today with my mentor, who trained me in dermatopathology, Dr. Cockerell, who's our invited presenter here, joining for this installment of Cases with Castle.
One question, Matt, before you go too far. Are you going to record this?
Yeah, so this session is being recorded, and we're going to be able to host this on kind of different post-viewing platforms so that folks who aren't able to join here middle of the day can review it at their leisure and kind of go back and review the cases as well and kind of see how people are thinking about incorporating gene expression profile testing into practice.
Perfect. Thank you. Just double checking.
So some housekeeping. So we are recording this session. We can either, accept live questions for those of you here in the audience, or put your questions into chat, and we'll be able to respond, kind of have an interactive dialogue around these cases. And then we'll send a link out to those people who joined here and make them available online for post-viewing here. Here are relevant disclosures here for this discussion. And I'll give a quick introduction here to Dr. Cockerell. Again, he trained me at UT Southwestern there at Cockerell Dermatopathology when I was a fellow in his laboratory. And Dr. Cockerell is the founder and president of Cockerell Dermatopathology, is the former president of the American Academy of Dermatology, and is a board-certified dermatologist, dermatopathologist, has an MD, MBA, and JD. So he's got the triple threat here of these different backgrounds as well, and is also the co-founder and educational director of DermPath On Demand for online educational resources in dermatopathology. He's really a luminary in the field, and really excited to have him join to give his perspective on incorporating gene expression profile testing into practice, and specifically around the MyPath melanoma test in selected cases from his actual clinical workflow. So I wanted to just start, before we pass over to Dr. Cockerell to go through these cases, to give a quick overview of Castle Biosciences, who we are as a company, what are the tests that we offer for dermatologists and dermatopathologists, and also give a background around MyPath melanoma. If you've joined other installments of these cases with Castle, this will be somewhat repetitive from that, but we put this here at the beginning to help those who have just joined for the first time get a background on our testing. So for Castle Biosciences, we provide molecular diagnostic and prognostic testing solutions for patients with dermatological cancers of high unmet clinical need. So essentially answering questions that face clinicians and their patients that they see in their clinic. And we have diagnostic tests such as the MyPath melanoma, which is a diagnostic ancillary test designed to aid in the diagnosis and management for patients who've been diagnosed with an ambiguous or equivocal melanocytic lesion. And then we have prognostic gene expression profile tests, the DecisionDx-Melanoma and DecisionDx-SCC test, that are prognostic gene expression profile tests designed for patients who've been diagnosed with cutaneous melanoma or cutaneous squamous cell carcinoma with one or more known risk factors. So these tests are used by dermatologists and dermatopathologists to inform their management of patients with these high-impact skin cancers or equivocal lesions in the case of MyPath melanoma. And as it relates to MyPath melanoma, which we'll be discussing primarily today, this is a gene expression profile test that's a diagnostic ancillary test, meaning that it's an approach used to better define a lesion that is difficult to characterize using the workflows of light microscopy or other stains, such as immunohistochemical stains that are often performed in the hands of a dermatopathologist interpreting a skin biopsy. And there's different types of questions that you can address and answer with diagnostic ancillary tests that relate to this central dogma of genetics, essentially. So there are different technologies that look at the DNA, such as FISH, fluorescence in situ hybridization, or array CGH, or SNP arrays that look at the particular mutational landscape of a tumor that tell you whether there's gain of function mutations or losses of tumor suppressors. You can find the mutational background of a lesion. And then on the far right, you've got protein expressions, whether you see the actual proteins in the tissues and This really speaks to immunohistochemical type approaches where you query with an antibody the presence, intensity, and relative location of a particular protein of interest in the tissue that you're evaluating. Gene expression profile tests are poised here in the middle zone here for RNA. This is the product of transcription and looking at what are the genes that are actually transcribed and looking at messenger RNA in the tissue to evaluate whether patterns of gene expression correlate more strongly with a particular type of lesion or a particular outcome in the case of prognostic testing. So these are different ways that you can look at DNA, RNA, and proteins to answer relevant questions in the diagnosis of our patients. And as it relates to gene expression profiling for equivocal or ambiguous melanocytic lesions, what this technology is founded on is that the gene expression that is contained in a group of nevi or benign melanocytic lesions may be substantially different than that gene expression seen in known malignant lesions, malignant melanoma. And so these gene expression profile patterns can be matched to these specific lesions, and algorithms can essentially classify lesions as more similar to the expression of a benign melanocytic nevus or more similar to a malignant melanoma. And this mathematical or algorithmic approach is how gene expression profile testing, such as MyPath, can distinguish between lesions that are suggestive of a benign neoplasm or suggestive of a malignant neoplasm. And these gene expression profile tests are developed through a rigorous pathway of discovery, training, and validation that are outlined here, starting with a large group of candidate genes that are then whittled down in evaluation of lesions with either known melanocytic nevus or known malignant melanoma groups to essentially identify where is there the largest difference in gene expression between these different types of lesions. Lesions are then, the algorithm is then trained on a validated group of lesions, and then validated in a completely independent group of lesions. And then subsequent performance cohorts can again evaluate the performance of this test in lesions with equivocal diagnoses or ambiguous histopathology. And essentially, these gene expression profile patterns are matched to malignant lesions or benign lesions as part of this rigorous discovery, training, and validation method that was used in the case of the development of the MyPath melanoma test. I also want to take a moment to outline how gene expression profile testing is performed when a specimen is submitted from DermPath Labs into Castle Biosciences. Essentially, this process starts when a completed test requisition is completed and sent to Castle. The slides are then requested and sent to Castle Biosciences, where a dermatopathologist, not myself, will actually review the slides to make sure that there is actual tumor content on the slides sufficient to support testing. It can be the case that a lesion is cut through and there's no remaining diagnostic material, and in that case, the tissue will not be processed for testing. When the lesion is confirmed to be present on the slides, goes through a process of deparaffinization. RNA is extracted through a specialized approach to extract RNA from formalin-fixed paraffin-embedded tissue. RT-PCR is then performed and quantified, and then this output of this material, the actual gene expression, is put into the validated algorithm, and then the report that is interpretable by the treating clinician can then be is then received by the ordering clinician to inform their downstream management for their patients. The MyPath melanoma test is based on gene expression of multiple relevant genes that are seen here, and also several control genes that essentially gatekeep the accuracy of each run of the test, making sure that the tissue is intact and can be essentially queried successfully for gene expression profile testing. The genes span biologically relevant domains of cell signaling, cell differentiation, and immune signaling, and the score is a logistic regression algorithm that has established cut points for lesions that are suggestive of a benign neoplasm here in the blue and suggestive of a malignant neoplasm here in the right. And these are then returned as the result to the ordering clinician. There is, of course, an intermediate zone, lesions that are different from benign or malignant, and that is also returned as an intermediate result on the test requisition form. We have a timeline of publications that's seen here. This beyond the scope of this presentation to go through each of these studies, but I've been referencing primarily the 2015 retrospective validation study from Clark and colleagues that established the discovery and initial validation of the MyPath melanoma test. But there have been multiple other validation studies that have demonstrated the high level of accuracy of MyPath melanoma to identify benign nevi as having a benign gene expression profile and malignant melanomas as having a gene expression profile suggestive of a malignant neoplasm with a very high level of accuracy. And these papers can be referenced here. We can happy to provide those if anyone has questions about any of these manuscripts, and we can discuss those offline at any point. The strength of this evidence has also led to guideline support for ancillary diagnostic testing approaches. And this really articulates that when dermatopathologists interpreting skin biopsies or treating clinicians who are faced with equivocal melanocytic lesions, they don't know what to classify a lesion or how to classify a lesion as being a benign nevus or malignant melanoma, diagnostic ancillary tests are certainly a place that dermatopathologists can turn to get to diagnostic clarity, to get to a specific diagnosis. And gene expression profile testing is one of the modalities that can be considered in cases where the diagnosis cannot be confidently established using light microscopy alone in histopathology. And as we'll talk about with these cases, the purpose of the discussion with Dr. Cockerell today and with this Cases with Castle series is to identify for equivocal melanocytic lesions, how do you incorporate gene expression profile testing into practice? Where does this become part of your diagnostic workflow? As the evidence supporting this is strong, it's been incorporated into guidelines for a technology that can be included as part of your diagnostic workflow, but where does it fit? And hopefully through the conversation here in these cases, we'll all gain a better understanding of where this can fit into your diagnostic workflow. Before I pass here, I'll pause for any questions from the group. I don't see any questions in the chat here, and we can move right ahead into cases.
Okay, well, thanks, Matt. I guess you're going to give me the
You
screen.
should have the control here of the machine.
Okay, so I should hit
Accepted. There you go.
okay. So basically what we have done here is just select a series of cases. These are just randomly selected. So when we're reading our cases out in a routine day, we're looking at, a fair number of cases, and we get many different melanocytic neoplasms for interpretation. And then when we come up on something that we're concerned about, we're not 100% certain of, somewhat equivocal, we will submit it for the testing in selected cases. I say we're probably averaging about one a day, maybe in some cases 2 a day. Some days nothing, but I'd say probably at least maybe 5 to 7 a week we're probably submitting. And so we just chose some random ones that we have submitted from IPATH over the last several months. This was a 25-year-old man who came with a lesion on his neck. This had been submitted for the tape stripping derm technique, and did reveal a positive result for the link. But there was no, actually the link was not detected, but PRAME was detected. So he did a shave biopsy of this, and basically it showed what we thought was just a little bit of an unusual feature. We thought it was probably an unusual nevus. This was a young individual. And one of the things I will say that I am using this test more frequently on is actually trying to avoid calling the lesion melanoma. So years ago, before we had any testing, any staining, or anything like that, if we saw an atypical lesion, we might just call it atypical melanocytic neoplasm and leave it at that. We might even call it melanoma or something along those lines. But I'd rather not diagnose melanoma in a young individual, because it basically will give them the diagnosis of melanoma that they carry throughout their entire life. Obviously, you want to get the accurate diagnosis, but we don't want to overcall it too readily. And I see a number of these lesions that do tend to get overcalled sometimes because of that. So this is the example of what the lesion actually looked like, and we'll kind of go through that. This is the Path Presenter technology. And so this is a shave biopsy. It's basically just a routine biopsy that we get on a routine basis, and it shows a little bit of coalescence of melanocytes at the dermal junction. There's a little bit of pagetoid spread. There's some slight spindle cell morphology to some of the cells in the dermis, and it's got some inflammation. So it's got several features that are slightly concerning for melanoma. It's not enough, in my opinion, to call melanoma unequivocally. Years ago, like I say before, I might have actually been suggested possibly evolving melanoma in situ in a nevus, and might have just signed it out that way and left it at that. But today, what I would do in something like this is call it something like atypical pigmented lesion in something like this, and then submit it for the testing. And so that's exactly what we did in this case. And so again, I just looking at this blind, it's got a number of features that are really quite suggestive of melanoma in situ in some of these areas, and even possibly some of the dermal component. Some people ask, do you do a lot of stains in your laboratory for melanocytic lesions? I don't do so many stains here. I've just seen a lot of cases of PRAME staining that's equivocal. And in my experience, a lot of people tend to read into the PRAME stain kind of what they want it to show. Usually if the PRAME is strongly positive, it's usually obviously melanoma in my experience. So I just am not a big fan of that. The P16 staining, I like a little bit better if I'm going to do a stain. But to me, the genetic expression profile is a more objective test, and it's looking at more genes than just a couple of genes. And so I personally think it's a more holistic and better technique than actually just doing some stains. And so this actually did come back as suggestive of a melanocytic neoplasm. So it was very helpful here because in my original histologic evaluation, I was concerned about it. Obviously, we wouldn't want to undercall something like this, but given the fact that it had some features of benign as well as malignant, I wanted to make sure that we kind of gave the best evidence that we could before we actually gave it a definitive diagnosis. So once we actually got this back, I did actually sign it out finally as a malignant melanoma. I believe it was a relatively thin lesion, but it was still signed out as a melanoma. So Clark's level 2, obviously a very good prognosis lesion. And that's one of the other nice things about the Castle MyPath test is that once you get this, you can reflex it to do the prognostic test if you want to do that. Obviously, I'm not sure whether this actually was submitted for the final prognostic test or not, but you would expect this to be a 1A, very low risk lesion. But still, rather than leaving this as equivocal, we were able to give it a definitive diagnosis based on this of a thin malignant melanoma. So that's a good example of where it worked. We didn't want to just give it if we could avoid calling it a melanoma, if this would have come back as likely benign, I probably still would have recommended re-excision, but I don't think I would have called it a melanoma if it would have come back as likely benign. But given the fact that it came back as likely malignant in the context of the histologic features, we felt confident in going in and calling it a malignant melanoma in a young individual. So again, that's a situation where I think you want to really give the person the most accurate diagnosis that you possibly can, given that they're going to carry a diagnosis of melanoma for the rest of their life.
And I think your comment on, not needing to get additional stains here, I think, in your training, you talk about how you can see that you don't need the SOX10 or the melan A here to identify where the atypical melanocytes were kind of scattered along that dermal epidermal junction. And by not getting those immunostains, you also, save the block space to be able to then send in for, gene expression profile testings as they're relevant as well.
Yeah, it saves the patient some money too. So that's yet another example. So this was another young person with a lesion on the nose. And anytime we get a lesion that's submitted as dysplastic nevus on the head and neck area, especially the face of an older person with sun-damaged skin, I tend to get really concerned about those kind of lesions. And in my experience, in an older individual, especially somebody that's had sun damage, diagnosis of melanoma in that setting is more common than dysplastic nevus. In a young individual like this, certainly they could have a nevus, a little bit unusual to get a dysplastic nevus on somebody's nose. Now, a lot of these are just kind of submitted because of the EMR, and they just kind of check off that. It may not have looked like a dysplastic nevus clinically. It may have just been just a regular garden variety nevus. But we looked at this. This did have some spitzoid features, a little bit of an unusual histologic finding we'll show in a second. And then, the fact that it was sent in as a dysplastic nevus on the nose, and we don't have the clinical photograph to look at, we don't have any more information than that. It's just a little bit of a yellow flag, if you will. And the fact that this did have some spitzoid features was another unusual finding. So here we have the path presenter, and you can see that it's a shave biopsy. Apologize for that. There we go. And looks relatively symmetrical at this power. It's mostly nested, mostly pretty symmetrical. So I really favor the diagnosis of benign lesion here, but it did have some, slightly unusual features. Some of these cells are a little bit large. They have abundant, cytoplasm, abundant melanin in the cytoplasm. There's a few cells above the junction focally. So it's got some slightly unusual features. And when something like this is submitted as a dysplastic nevus, which is more commonly, not seen on the nose area, it made me wonder whether the clinician really was kind of worried about melanoma. And you can see some of these cells are really quite large and somewhat pleomorphic. So there's some spitzoid character, and there's two different populations. There's a smaller population of a more benign, typical appearing nevus here, and you've got this second population of cells up here. So could it possibly be, the last case was another 25-year-old person. I mean, could this be yet another example of an unusual melanoma arising in association with a nevus that to the clinician at least looked like a dysplastic nevus? So we decided to submit this for the testing as well. Again, didn't do any special stains, just went ahead and submitted it straight for the test, which, to me, is really probably, I just personally think it's a better test than doing the stains. So I just reflexed to this rather than doing the stains. And this came back as intermediate. A lot of people sort of don't like intermediate, sort of like, well, you're not sure on the H&E, and then you get back a intermediate quote, you're not sure on the gene expression profile. But actually, real world, nothing really should be binary. We know that certain things look sort of unusual histologically, they behave unusual clinically. So to me, it's sort of nice to actually have some uncertainty in a test as well. If it's just purely binary, maybe you figure it's overcalling or undercalling certain things. So to me, I actually like the fact that it does have an intermediate result in it. So what do you do in a situation like that? Well, I favored, based on that was most likely just an unusual nevus in a young individual, had these spitzoid features, but I wasn't just going to leave it alone. I recommended either, conservative removal, or at the very least, conservative careful monitoring. And if it recurs, then to take another biopsy or remove it at that point. Certainly didn't feel like it was enough to call a definitive malignant melanoma, but definitely had these unusual features and recommended, given it's a young individual, something conservative be done rather than treating it like it could possibly be malignant melanoma. Obviously, on the nose, you diagnose it as a melanoma. You're going to then basically do a deforming 1 centimeter surgical removal of that. We didn't have a diagnosis of melanoma here, either clinically or genetically. So to me, careful evaluation with conservative removal would seem reasonable as opposed to treating it like it could possibly be malignant melanoma. So in this case, the test helped us, didn't get it into a definitive diagnosis of melanoma, and allowed us to recommend something more conservative rather than a more aggressive approach.
And I think that highlights the value of the 3 different types of test results that you get, right? The intermediate result doesn't instantly place you in malignant or benign category, but it really is a case-by-case review of the other clinical pathologic features, the case scenario that drives how you counsel, how you write your report, and then how you subsequently message this to the dermatologist treating the patient or surgeon treating the patient.
And that's a good point too, because what I will do, depending on the situation, is get an initial diagnosis of either something like just atypical melanocytic lesion, generic, and say that I'm doing the testing. Some cases I'll say probable dysplastic nevus, unusual features, going to submit it for the initial genetic testing, or probable spitzoid lesion or atypical spitzoid lesion, then I'm going to submit it for the additional testing. So I don't really just use the same sort of generic diagnosis of uncertainty, equivocal diagnosis each time. I basically try to tailor it to what I'm seeing, and then at least the clinician knows that, well, this one's kind of got some unusual spitzoid features. This one sort of looks like a dysplastic nevus. Other cases, it's just atypical and equivocal, and then he's going to, be submitting it for the testing. So we don't really have a one-size-fits-all, but we do give a preliminary diagnosis and then submit it for the testing, and then incorporate the results of the test in our final diagnosis.
That kind of detail is helpful, just to think about how do you physically do this? How do you work that into the sign out process, and the prelim to then final is a nice way to kind of alert the clinician this is coming, but then also issue the final report that includes a mention of the test result and what it means for the final diagnosis.
And this next case, as you can tell, all of these 3 cases initially are in young individuals. And I would say that I'm using the test more commonly in younger people than I am in older individuals. Although, interestingly enough, we just received back a likely benign lesion on a spitzoid lesion in a 68-year-old person, believe it or not. So it was an atypical spitzoid, submitted it, just came back as likely benign. So I didn't just say, well, we're just going to leave it alone. I still recommended re-excision of that lesion because it was a little bit unusual histologically. But most of the cases I'm submitting today are these kind of lesions that are relatively young individuals that and if, let's say you get one of these atypical lesions in a 65-year-old person, well, you might just go ahead and just call it a melanoma and say, well, it's got, maybe 8 out of 10 features that favor melanoma, rather than really working it up those last 2 or 3 criteria. It's more likely going to be melanoma, so you just go ahead and call it a melanoma. And in that situation, it's not as critical as it is in a younger individual, where you absolutely, it's a problem if you're carrying around a diagnosis of melanoma for, 50, 60 years, because that's going to raise their insurance profile. They're going to be treated like a melanoma patient. So to me, I'm using this more and more to avoid overdiagnosis these days. So this was an example of one. It was in an acral site. So that's an area you can sometimes get some atypical histologic features. It was a 12 by 8 millimeter lesion, so a relatively large lesion. This we thought was probably a Spitz's nevus, so I apologize for that typo that didn't get fixed there. But we favored again the Spitz's nevus in an acral site, but because it was a little bit funny, we said, well, let's just send it off and basically give the patient the benefit of the doubt and just make sure there's nothing that's going to genetically change our mind. And so here you see the lesion, and it's on an acral site. It shows to me, it's a pretty good biopsy. I think it's probably gotten most of the lesion out. It's really quite symmetrical and pretty well circumscribed. And it's got the epithelioid cells that are spindle and whatnot. So it really looks pretty good for a pigmented Spitz's nevus. And I favored that significantly just by looking at the histology. It had a couple of cells above the junction, didn't really have any mitotic figures. It's got the epidermal hyperplasia. So again, I think years ago, we might have just called this lesion a Spitz's nevus and kind of moved on to the next case. These sort of pigmented spindle cell lesions, and a lot of the new WHO is classifying some of these lesions as melanocytomas now, lesions of sort of indeterminate biologic behavior. I'm not sure I've totally bought into that entire scenario just quite yet. I think a few years are going to be required to sort of see how that all plays out. But at least this lesion, if some people saw this, would say they would call it a pigmented spindle cell spitzoid melanocytoma. And they would, kind of leave it as possibly being an indeterminate lesion. So we favor benign here, but went on ahead and submitted it for the genetic testing. Interestingly enough, it came back as suggestive of a malignant neoplasm. I sort of still didn't really totally believe that. And I don't always believe that in every case. And so even though it came back as likely malignant, that doesn't mean that it's malignant. And so I think this might kind of correlate with what these people are now calling these melanocytomas. They demonstrate some unusual different genetic features than other types of nevi. And so that may be what the gene expression profile is picking up here. And a lot of people might call this a lesion with some so-called indeterminate biologic behavior. I personally think it's more likely just a variant of a Spitz's nevus, and we just recommended, because of the genetic profile, to completely excise it. But given a 19-year-old individual in that location with that histologic features, it's almost certainly going to have a benign biologic behavior. And since this lesion was excised, there's been no history of any recurrence or any spread or anything like that. So that's a good example of where the test may be picking up some genetic abnormalities, but it may not really be a truly malignant neoplasm. And I think that's something to kind of keep in mind, that there is this sort of family of these lesions now that are being called these melanocytomas that have genetic abnormalities, behave in a biologically overall benign fashion, the vast majority of the cases, but occasionally they might spread to a lymph node or something along these lines. And so I think that may be why people are now classifying some of these as an indeterminate type of lesion that do express some different genetic profiles than one might expect otherwise.
And the clinical actionability here is to mandate re-excision for this lesion to make sure it's completely removed based on the genetic profile in a lesion that you may otherwise have, say, recommended no further treatment is needed potentially. So you're kind of between you didn't change the top line here, but you did modify kind of how you recommended the patient be managed effectively.
Exactly. And the interesting thing, the 68-year-old guy that we just got back the result today was kind of the reverse. That's one where I was kind of almost expecting to come back as malignant, and it came back as likely benign. In that case, I still didn't feel totally comfortable just leaving something like that alone when it was somewhat atypical histologically in an older individual. So, I think we recommend removal of that lesion as well, just like we did here. But hopefully they'll both have good long-term outcomes. Another individual, relatively young person, a 29-year-old lady with the lesion on her mid-upper back. We got a shave biopsy here to rule out a dysplastic nevus. And our biopsy here was that it was a little bit unusual. It had some epithelioid cells here, again, sort of a spitzoid morphology and maybe a little bit of slight pagetoid spread. So we'll take a look at what the lesions look like. And I'd say these are probably maybe among the most common lesions right now that we're submitting for the testing. These kind of lesions that look kind of like a dysplastic nevus, but have more cellularity, a little bit of pagetoid spread, maybe some slight asymmetry. So you see, this isn't a prepared case like for a lecture. It's got a couple of folds in it. So this is a real world case that we just saw not too terribly long ago. And if you look at it at higher magnification, it's mostly nested. Some of the nests are relatively large, are kind of beginning to sort of fill the papillodermis a little bit. There are scattered cells focally above the junction. There is some maturation. So overall, I favor this being a benign process, but it does have some slightly unusual features. Didn't see any mitotic figures. And so, maybe I can see why I sent it off here, because it's got some of the slight asymmetry and this papillodermal stuffing, which is somewhat a sign of malignancy in some cases. So again, right here, there's some epithelioid cells. So it's got some clones of cells that demonstrate some slightly unusual features. I favor benign, but this is the type of lesion they say, it's just got enough unusual features that it really warrants submitting for the additional testing, just to be on the safe side. Again, years ago, when we had no tests available, we'd probably call something like this a compound nevus with some unusual features and just recommend excision. I don't think I would have called it a malignant melanoma, but that's the way we would handle this, 25 years ago. Today, we can say, well, let's see if we can get some more information. And if this were to come back as likely malignant, we're going to probably we might call it melanoma. If it comes back as likely benign, we're probably going to recommend removal anyway. But it certainly would be nice to know whether to recommend a wider excision versus a more conservative excision. And so we did submit this off, and this came back as suggestive of a benign lesion, came back with a fairly low number. And again, it's not necessarily that the lower the number means the more benign. We find that some of the blue nevi, sort of cluster down in the 16.7 area. They're very low. Some of the dysplastic nevi that are benign kind of cluster in this area. And then occasionally we see some spitzoid lesions that are benign kind of cluster closer to the 2 number. So, but it's not necessarily that the lower the number, the more benign the lesion. This one came back as negative 9.4. So it was probably in that kind of dysplastic nevus sort of area where we favor that just sort of tends to, cluster in that area. So we call this ultimately a dysplastic nevus with some unusual histologic features, just recommended conservative removal. And if this would have come back as a suggestive of malignancy, again, I don't know for sure I would have just necessarily just called it a melanoma, but I very well might have, given some of those features. Certainly would have ended up probably getting a wider excision had it come back something with a little bit more aggressive gene expression profile. Any comments about that one, Matt? All right, I guess we'll move on to the next case, number 5.
So I was on mute there. Sorry. It's a situation that when margins matter, right? This is the kind of technique that you can, titrate your recommendations for the clinicians that we serve. So you can essentially not obligate someone to do a 4 or 5 millimeter re-excision for complete removal with a margin of normal tissue on a lesion that has a biological profile that, suggests that the lesion is best classified as a benign process that may be sampled incompletely. It extends to the margins and extends to the deep margin, may benefit from complete removal, but not with a safety margin because the biological risk of the lesion is quite low.
Yeah, and I think that's a really good use for the test. I totally agree with that. Next case, again, a relatively young individual, middle-aged, lower leg that was thought to be a dermatofibroma. So here they weren't even thinking of a melanocytic neoplasm here. And so once again, here we had an atypical spitzoid process. Okay, this is not a child. It's a man. We know that Spitz's nevi occur most commonly in children and in younger to middle-aged women. So when you get a male that's got a spitzoid lesion, obviously it's a little bit more of a red flag. And so this one was, again, a little bit of an unusual lesion. And so we decided to submit this for the genetic testing as well. And here you see the lesion, and it's got a fairly cellular morphology. So you can see why they might think it might be a dermatofibroma. It's got a very dense, almost desmoplastic stroma here. Cells are really quite epithelioid, and there is a variant of a Spitz's nevus that can look very, very much like this. So we call it an atypical spitzoid melanocytic lesion. So what's the atypical component of it? Well, the cellularity of it, the fact that it's not in a child. There's some overlying prominent paginoid spread of melanocytes throughout the epidermis. There's this cleft here. So, and I think that's actually not just a histologic artifact. I think that's because of this desmoplastic stroma, and there's actually a loss of the contiguity of the epidermis from this abnormal stroma, almost like what you see overlying, say, a scar. So I don't think this has been previously biopsied at all. This was exactly what the lesion looked like. And you can see it's got a lot of epidermal involvement. We don't have the entire thing to look at the symmetry and circumscription, but it's got a fair bit of paginoid spread in the epidermis. And then it's got these large numbers of these very spindle-shaped epithelioid cells in the dermis here with this prominent stroma. So again, this could very easily be a benign lesion. There is a variant of a Spitz's nevus that could give you this, and this might be one of these 11p mutated nevi, and there are people now that are doing not only gene expression profiles, but they're also doing fusion studies on these lesions and seeing what kind of fusions are in here, seeing if there's a TRK fusion or ALK fusion. And so certainly that's something else that could be done for something like this. But I think the gene expression profile here is going to give us more information as to whether we're dealing with a benign or malignant process more likely. You see this high magnification view. The cells are relatively uniform. There's not a lot of mitotic figures. It's just the cellularity and the diffuseness of the process with the prominent paginoid spread overlying that really kind of gave us some pause here in a 40-year-old man. Well, the good news is it came back as suggestive of a benign lesion. And once again, the Spitzoid kind of number, the 3 to 4 kind of categories, kind of where we see this. So this was quite reassuring. I mean, basically you've got an atypical appearing histologic lesion that's got a suggestive of benign process. I don't think we're going to leave this alone. We're still going to recommend removal of it. Very cellular, very dense, relatively large lesion in an older individual with all that paginoid spread. But nevertheless, I don't think this gives us a reassurance that this thing is not really a malignant melanoma. So the good news is here, recommended excision, but certainly we didn't have to upgrade this to malignant melanoma. So this is sort of a little closer to that case that I just saw, was alluding to today in the older individual. It gave us some a very good sense so that we're dealing with something that's more likely benign than malignant, unusual, maybe one of these fusion Spitz's nevi, but certainly something that we would recommend removal, but not call a malignant melanoma. So very, very helpful in that situation.
And that one is in contrast to the dysplastic nevus or the more compound lesion that was 0.2 millimeters in the earlier cases. This is a high stakes case where if this is a malignant melanoma, this is a T3 at least, primary. So you're between, a high stakes melanoma diagnosis versus a Spitz nevus. It can be a trigger to thinking about, doing diagnostic ancillary tests generally in a high stakes case. But I think the other cases also highlight how you can use the same approach or need for diagnostic ancillary tests in lesions that don't have, obviously high stakes like this one has, but you can use it in kind of both of the scenarios for when there's margin questions for lower stakes lesions, but also higher stakes lesions like this.
That's a really good point. And, basically, I like that high stakes, low stakes kind of thing, because if something like this is malignant and you call it benign, well, you're going to court, basically. If it's malignant and it's called that, obviously that's going to be important for the patient because that's going to be a lesion that's going to require wide excision, sentinel lymph node biopsy, all that type of scenario. But the fact that this came as benign, even though it was benign genetically, we still recommend a removal. But it's very reassuring when you get something like this in one of these situations where the lesion looks histologically somewhat nefarious. All right, I think this may be our last case.
I think so.
And this was, again, an older individual now. Once again, just like the 68-year-old man I was telling you before, well, here's a 68-year-old woman who comes in with a pigmented lesion on her back, and it was thought to be either a nevus, hemangioma, or melanoma. So there was clinical concern about it. But there was a benign differential diagnosis as well. And so this is one that showed some unusual findings again. It showed some slight epithelioid features to some of the cells. There were a little bit of asymmetry here. So once again, these are equivocal for various reasons. Sometimes it's because they have a spitzoid morphology to them. You want to make sure that's not really a spitzoid melanoma. Sometimes it's some asymmetry. Sometimes it's some pagetoid spread. Sometimes it's the density of the, involvement, like the last case. So they're kind of like snowflakes. Everyone's a little bit different. There's not one sort of animal of an equivocal melanocytic lesion. There's lots of different reasons that they're equivocal. So this one had some of these features that are in the histopathologic description there, and we'll take a look at some of these in the actual slide. And so I think this is probably it's got two areas. We'll look at this one first down here. So you see this kind of has the overall architecture that looks like a dysplastic nevus. It's got the epithelial hyperplasia. It's got a central focal junctional component and maybe a little bit of a dermal component, but it's got the bridging and whatnot. So this part kind of looks like a dysplastic nevus. But then let's look at the top portion of the lesion. And obviously it's important to look at all the sections. And here you see some more single cells at the junction that are more coalescent. There's maybe single cells predominating over here. There's a little bit of pagetoid spread. So those are some areas that are a little bit concerning. And then the uppermost portion of the lesion up here had some inflammation. And this is the area that had some of the more epithelioid cells in here. And there's a little bit of histologic artifact here that kind of made it somewhat challenging to diagnose. So this one didn't have a very spitzoid morphology. It was inflamed. It looked like a dysplastic nevus in some areas. It's got some single cells. It's just like pagetoid spread in other areas. It's got all this inflammatory infiltrate here in this area. So these are the reasons that this specific lesion looked somewhat equivocal to us. So again, one size doesn't fit all. I mean, this, what's going on here in a 68-year-old woman that she's got these areas where there's some single cells at the junction and you've got this prominent brisk inflammatory infiltrate. Very unusual to see that in a common garden variety melanocytic nevus. So we submitted this. It still could be benign, just an inflamed dysplastic nevus with some slightly unusual features. And so I wouldn't say that it's enough to call an unequivocal melanoma, but it's got enough features that, would you feel totally uncomfortable just calling it a benign nevus next case? So the answer to that's, probably not. So we submitted it, and guess what? It came back as suggestive of malignant neoplasm, given the fact that it had those features that I just showed you before, had that inflammatory infiltrate. We decided in this case that we're just going to upgrade the diagnosis and go ahead and call this a malignant melanoma. And ultimately we ended up calling it a Clark's level 3 melanoma with those dermal cells with all that inflammation focally filling the papillary dermis, and it measured out at about 0.7 millimeters. So here's one that was atypical. The inflammation said, well, maybe the differential diagnosis is just severely inflamed nevus. Submitted it, came back as melanoma, said, great, our original potential differential diagnosis of melanoma is correct. And we're able to just basically give it an unequivocal diagnosis here, and she got treated appropriately. So that's one where we had pretty good suspicion of melanoma, but we didn't want to just overcall it just right out of the block. We want to give it the benefit of the doubt. The test came back, kind of confirmed our original impression, and ultimately she was treated appropriately. So those are several different scenarios of how we're using this test in our laboratory. Again, some are used in situations of younger individuals where you don't want to, overcall it. Some in a situation like that where you feel pretty comfortable that it is melanoma, they say, well, is there a chance it could be benign? And in that case, it was no, it really couldn't be benign. And so that's just kind of some of the different ways we're using them. Some of them look like dysplastic nevi that are inflamed. Some of them look more like spitzoid lesions that are inflamed. Some of them look just like unusual sort of lesions that have some criteria for melanoma and other criteria for nevi, yet they come back as likely malignant in some of those cases there. So to me, it's a very helpful test. We're using it literally just in a routine part of our practice on a daily basis. We're not submitting anywhere near the majority of lesions that we get. We're only submitting just maybe one or two per day out of hundreds of lesions that we're diagnosing every day. So you don't need this for the vast majority of lesions. But when we do get cases like this, it's, in my opinion, it's extremely helpful, and it's really transformed the way that I practice signing out pigmented lesions.
Well, Dr. Cockerell, thank you for joining us and kind of going through these cases. And I like the method of taking real world cases that you've encountered and talking through your thought process of what kind of triggered you to order them, how you thought through the results, how you thought through the histopathology in the context of the gene expression profile test results. And I hope that's helpful for folks joining here or either now or kind of in post viewing to think about how these tests can add value to your practice and sign out, and also then in subsequent interpretation of how these lesions are managed. We have time for questions. I don't see any questions in the chat, but I'll open here. If you have a question, you want to raise your hand, we'll be happy to let you ask a question here live on the Zoom. All right. Again, thank you all for joining here on this Thursday afternoon, and Dr. Cockerell for joining and sharing your cases with us. Thanks to the organizers. Oops.
We did get one question, Matt. That just
do you see a question here? Yep. Okay, so this is a case discussion here. Dr. Cockerell, can you see the question here as well? I'll let you address this one.
Up there too. Yeah, so I can read it, or you can read it. Basically, it was a fellow with an atypical junctional melanocytic lesion. He was concerned about evolving in situ. There was a scar suggesting possible recurrence, but no history of a prior biopsy. Yeah, we see that ourselves too. A lot of these look like there's some fibroplasia there, and there's no history of any procedure. And so that's probably a little bit of a desmoplastic component. But it sounds like then you got back a result of indeterminate. You still were concerned about melanoma in situ, recommended complete excision. That's exactly what I would have done. It's precisely the way I would have handled that. Came back indeterminate. I would say, well, there's still some enough histologic atypicality here. I'm not just going to leave it alone. You could still call it something along the lines of possible evolving melanoma in situ, indeterminate result, recommend treating that way. That's absolutely appropriate. And so that's the exact way that we do that. And we see those exact lesions in our practice at least a few times a week. So I know exactly the kind of thing that you're talking about there.
And from my perspective here, when you as with all the results, but I think with the intermediates, as Dr. Cockerell's example highlights, you're really obligated to think about the lesion in the context of the other things that you know about the case, the clinical, the histopath, other stains that you may have, or other ancillary tests in the context of the gene expression profile test. So it is kind of it is a case by case interpretation of what you'd do for that particular case. And so I think Dr. Cockerell's intermediate case is a good example, and this is another good example of how you handled in your practice the intermediate result in the context of that patient's histopathology and particular clinical scenario. All right. We'll hold just for another round of questions here. If anybody has other questions, we'll be happy to address them. All right. Thank you all again for joining. And Dr. Cockerell, really appreciate you being here, and for the organizers who put this together. Hope that you've enjoyed this, and stay tuned for future installments with other dermatopathologists talking through their cases and their approach to gene expression profile testing for these ambiguous melanocytic lesions. Hope you enjoyed, and see you the next time.
Thanks a lot.